I'll try to answer it, and I want to congratulate the organizers on the 10th anniversary of this magnificent congress. So if we talk about fluorescence-guided surgery in rectal surgery and about anastomotic leaks, then I focus, of course, on perfusion imaging because that's what we try to do. Image the perfusion with the aim to prevent the anastomotic leakage. So that's what I'll focus on. But is fluorescence imaging or perfusion the only thing that leads to anastomotic leak? No, of course not. I just show a slide of a Dutch trial, which is a multimodal intervention, especially on the left side of the image you see what we do in this trial to try to prevent anastomotic leaks. There's this discussion going on about antibiotics or not, bowel prep, but the other thing is tension on the anastomosis, and in this trial there's a standard splenic flexion mobilization, and of course there's fluorescence imaging. On the right side you see how you could early treat a leak. Because it's the 10th anniversary, excuse me, and because already the history has been mentioned, I do it again, and I want to show you the build-up of the evidence on this topic. And in 2018, we published, and others did as well, a review, and at that time we had these papers, which were in a large part feasibility studies, sometimes already case-controlled, but not that many yet. Then also it was shown it was easy to use, there was little added surgical time, no complications due to the technique. There was a change of resection margin, then because of insufficient fluorescent signal in 10% of cases, with a reduction when FGS was used, reduction of anastomotic leaks. And interesting, in patients in whom the resection margin was adopted because of insufficient signal, after revision, even then, there was an enhanced leak rate of 8.9%. So there's a bit more going on in this subset of patients that you identify with fluorescence imaging. And when there's good perfusion, then you get your 2.8% leak rate. A couple of years ago, in a congress of the European chapter of the ISFGS, and I want to congratulate Fernando and Raul for developing such chapters all over the world. But anyway, then in 2021, I showed this slide on meta-analysis. So you can see there was really a huge buildup of literature, and even then there were quite a couple of meta-analysis possible. I'll show you one. This one. It is about colorectal surgery, and I'm aware that I'm to talk now about rectal surgery, so I'll focus on rectal surgery. And here again you see a significant reduction in anastomotic leak rate when fluorescence angiography is used. You see a low anastomotic leak rate, and in all the subsets of low resections you see the same kind of reduction in anastomotic leak rate. So you would think, okay, stop the talk now, it's clear. Well, but there is more evidence. I'll show you. This is interesting. Of course, I show the other results as well, and this is one, the Pillar 3 trial. You all know about it. It's been performed here. And yes, there was a successful visualization of perfusion, but there was no difference in anastomotic leak rates in this trial. So how come? I'm not going deeply into the how come. I'll show you some more results, and maybe we in the discussion can discuss a little bit on how come that some studies don't show the result, but the overwhelming majority does. There are a few meta-analyses, and I want to show you the latest randomized trials. These are the most recent meta-analyses. I'll discuss them with you. From the EAES is one. It is called a consensus conference or a paper, but in effect it's a meta-analysis of 30 studies, high quality, randomized trials, prospective and retrospective, but all comparative studies. The great methodology was used. This is an interesting, I think very important forest plot. If you can see this, and this is how a forest plot should look like to tell you that an effect has been achieved. It's all on the left side, which means it's in favor of fluorescence imaging. And when there are studies that are not on the left side, you can see that the interval overlaps. So that made the authors claim that fluorescence imaging works for this indication. And especially it says that the use of IgG fluorescence significantly reduces the risk of anastomotic leak, and they dare to say that the level of evidence is high. And the second thing is it can lead to a change in the resection line or refashioning of the anastomosis. So that's the EAES in 2023. Then 1 year later, this one from the Yves Pani, the French group. All papers included, the same kind of papers, and especially indeed the same papers. They looked at the ABC anastomotic leak. I'll come to that definition in a couple of slides. And then again, you can see a reduction in anastomotic leak rate. Already here you can see that the absolute figures for the anastomotic leak rates, they differ a bit. I'll come to that later. The number needed to treat to prevent one anastomotic leak is only 22 patients. I think that's quite a reasonable number. Then from Ronan Cahill from Dublin, very interesting group, very interesting research they do, and they had this meta-analysis. Again, the same kind of papers, and it will not surprise you that in these 5,000 patients, again, the overall result is in favor of using fluorescence imaging, with a number needed to treat in these papers of 29. And again here, the change of plan, when the ICG signal is the same as what the surgeon with his own eyes interpreted, then the anastomotic leak rate is 5%. When the ICG prompted change because the signal was insufficient, then you have a higher leak rate, but the highest leak rate you will have if you don't use ICG. Quite impressive. What is also impressive is this webinar from the European chapter of the ISFGS, been organized by Alexander Varmeyer, December 2024. And here the 4 latest randomized trials were discussed. And I want to share you these slides, and I made some screenshots, especially to show that I got these slides from your excellent webinar, Alex. 3 trials from Japan, from the Netherlands, and from the UK. Watanabe published this, he discussed it also in the webinar. And he showed this slide on different anastomotic leaks. And it's in Japanese, so we don't know what he really tells, but I can tell you that indeed there is a difference in different trials or studies regarding the anastomotic leak. It's important to have the right definition and use all the same definition. The ISGRC, International Study Group on Rectal Cancer, they defined it, they validated the system, and here it says in small letters what it is about. It's about indeed seeing a leak, but also having a collection close to the bowel or to the anastomosis without seeing actually the leak. This may seem a very strict definition, but still you can imagine that in different research projects or different hospitals, still the definition is applied a little bit different. And that may explain differences in anastomotic leak rates reported. We talk about ABC leaks. A is a leak which doesn't require an intervention, B does, and C asks even for a re-laparotomy. And just a slide on the different anastomotic leaks. It's also, of course, about the period of time you follow your patients. This is a snapshot study from the Netherlands, and you see within 30 days, it's 30%, but when we follow the patients longer, indeed, the late leaks will become apparent as well. The essential trial, in the red square, you can see that the primary endpoint was the grade A, B, and C leaks. Interesting and very important is how long do you look at the image to define whether the perfusion is excellent or not, or sufficient or not. 60 seconds was taken in this trial, and when the signal took, or the ICG took more than 60 seconds to reach the proposed anastomosis site, then the perfusion was deemed poor or no perfusion, and then a re-resection took place. Looking at the A, B, and C leaks, there is an advantage, which is shown here. The secondary endpoint was only the B and C leaks, and there again, there is an advantage. Interestingly, only in 2.5% of their patients, the anastomotic site had to be revised and an additional resection took place. In case of poor or no perfusion, only few patients, but interestingly, after revision of the resection line and making the anastomosis, these patients had a high leak rate. So there's more going on in these patients than only can be corrected by revising the anastomotic line. A void trial from the Netherlands. The two PIs are Alexander Varmar and Denise Hilling. You can see her, very small, but on the right upper side of the slide. Again, assessment of the image or the signal within 60 seconds. The primary endpoint, grade B and C leaks, and already shown by Alex, there is a yes, which means there was an anastomotic leak, and in the FGBA group, fluorescent guided bowel anastomosis, compared to the control group, there was an advantage. There is a p-value, which makes it valid for the left-sided resections. I should focus on the left-sided resection, so I do that. But in multivariable analysis, that seemed not to be the case. Although you see the odds ratio, you see the p-value, okay. And then the change of surgical plan in about 10% of patients, 41 of the FGBA group. And then on the right side, you see in this group again, there was after revision a 12% leak rate, which is almost as high as the control group. And then the last trial, the INTACT trial from David Jane from Leeds, it has not been published yet. Again, the BC leaks as the primary endpoint, secondary endpoint. All leaks. Here is the slide about the primary endpoint, and here you see in red the surgery with IFA shows an advantage of using the ICG, and when we look at all the endpoints, you see that again. So, and then here again you see the a number of revisions of the anastomosis. We at this moment know very well. It's all in all these series about 10%. So this is how I look at the subject, not on politics, but especially on this subject. Yes, it can. I think after all these trials, all this evidence, there's only one answer. Of course, you have to look in depth at all the trials. Why is it that the leak rate is different in one study than the other, or maybe in some studies it appears not to be relevant? There is something about technique, there is something about dosing. Of course, we can discuss that later on, but I think in general, yes, it can help us prevent leaks and enhance outcome. So then, it has been discussed already, just a couple of slides. Why then don't we all use this FGS4 fluorescence imaging in colorectal surgery? Well, it's expensive, it costs time, it's cumbersome. There's something about an horizon with a specific system, and it's not available in all ORs. And this is an interesting paper from the group of Ronald Cahill. It's in plastic surgeons. Everything that's orange, that are surgeons that have objection against the application. And all the reasons for not using it are mentioned. And you see that in general, at this time, half of our colleagues think, it's not interesting, I don't want to use it. So there's a lot of work for us to do. Okay, it does reduce anastomotic leaks, fluorescence imaging, yes, especially if you look at all grades of anastomotic leaks. And it's about in 10% of patients that we can revise the anastomosis, but still, this is a group of patients we have to look at in detail. Thank you for your attention.